Hello everyone, thank you for joining us for this webinar. My name is Alexis LaPietra, and today we are going to be talking about alternatives to opioids for pain management in the emergency department. So a few numbers to start off with. 1.9 million is the number of Americans that are currently abusing or misusing opioids. 75% is the percentage of heroin abusers in treatment that state they started using heroin after becoming addicted to prescription opiates. This is a stark change from what we saw 30 or 40 years ago, where 95% of heroin abusers in treatment stated they started using heroin when they started using heroin. So we see now a shift from heroin users starting their opiate addiction with heroin, but now opiate addiction starts with prescription opiates and unfortunately later transitions to heroin abuse. 51 is the number of Americans that die every day from an opioid overdose, which is about 18,893 Americans every year that die. This is rapidly becoming the number one preventable cause of death nationally, opiate overdose. This also affects extremes of age when we think about seniors and pediatric patients. So when we often think of opiate abuse, we are not thinking of geriatric patients. However, we see that there are 2.8 million geriatric patients that are abusing or misusing opiates every year. This is multifactorial, but part of it is geriatric patients listen to their physicians. And when they hear the physician say, take this medication every 4 or 6 hours, they often don't hear the PRN or as needed for pain part. So they continue to judiciously take their medication every 4 to 6 hours. And when they get to the bottom of the 15, 20, or 30 tablets, this population is unfortunately addicted to that medication physiologically. Also, we look at pediatric patients, and this population, we don't typically see practitioners prescribing opiates to pediatrics. What we see are that the young adults see these pill bottles in mom, dad, grandma, grandpa's medicine cabinet, and they have a piqued interest and they recreationally use these medications. So we have about 467,000 adolescents that are currently non-medical users, and also 168,000 that are addicted. So this goes just beyond prescribing. This also goes to thinking about how many tabs you're prescribing, because there is an excess of this medication in the community, and that can lead to unnecessary use and abuse. So this epidemic is multifactorial, but as we saw more and more opiate addiction, we looked and saw, wow, there was more and more opiate prescribing. So we all know the story that in the early 90s, there was a push for better pain management and documenting pain scores more judiciously. And there were not a lot of tools in practitioners' toolboxes, and I think that it was well-intentioned prescribing of opiates that got us here, but the more opiates that we are prescribing, the more addiction that we see. So in the emergency department, when we see patients and we see patients with acute pain, our number one goal is to get them feeling better. Again, as mentioned earlier, when we think about what we have to help patients feel better, I think practitioners feel that they only have a few things in their toolbox. They have Tylenol, they have anti-inflammatories, and if neither one of those work, then they have opiates. And often, opiates are treated as a first-line medication. But what we found is with liberal opiate prescribing over the past 2 decades, that has led to significant addiction. So although opiates are important, and we have to utilize opiates when necessary for certain kinds of pain, this reflexive prescribing of opiates has unfortunately led to a terrible opiate crisis and significant addiction. Therefore, looking now at more pain management research and seeing what medications are out there, researchers and practitioners have discovered there are a multitude of alternatives for specific conditions that are as effective, if not more effective, than opiates. So let's try and decrease opiate use, therefore stopping some of this addiction, and we're going to do that by using more alternatives. At St. Joseph's Regional Medical Center in Paterson, New Jersey, we developed a program called ALTO, or Alternatives to Opioids, and this was a program that was developed again, based on the opiate crisis and the belief that there were definitely medications or modalities that we could use in lieu of opiates, not because we didn't want to give opiates, but we wanted to do better. We wanted to elevate pain management, successfully treat patients, but we also wanted to reevaluate the need for first-line opiate prescribing. The 5 conditions that have great evidence that alternatives are as effective or more effective than opiates are renal colic, musculoskeletal pain, lumbar radiculopathy, migraine headache, and extremity fracture dislocation. And because you're watching an ultrasound-focused podcast, what we're going to talk about today is ultrasound-guided regional anesthesia. This is a fantastic modality for the management of extremity fracture dislocation pain. So why is this good? Why do we want to learn about this? Well, it is, first of all, targeted, focused pain relief. When we administer opiates systemically, the side effect is the brain gets foggy and, well, they forget about their pain. But with ultrasound-guided regional anesthesia, you can put local anesthetic exactly where the pain is coming from and completely stop that pain. There is no amount of opiate that's going to safely completely resolve fracture or dislocation pain. So this is a major plus for ultrasound-guided regional anesthesia. It is also long-acting. When we think about opiates, morphine, one of the longer-acting intravenous opiates, we're not getting all that many hours of analgesia. But when we administer certain long-acting local anesthetics, we can have up to 12 or 24 hours of relief. And if a catheter is placed at that site, we can have days of relief. So this is long-acting, complete pain relief. Additionally, when patients are potentially unstable, their vital signs aren't looking great, we may not want to give them large amounts of opiates, but we can perform a nerve block. There's no vital sign changes that we see with the nerve blocks. And lastly, it's a hands-on procedure. There's instant gratification, and it is billable when you perform it. So it's a win-win situation. In addition to the Sonosite ultrasound machine that you'll need at bedside to complete ultrasound-guided regional anesthesia, there are a few other things that you would need. First of all is patient consent. The only contraindications to doing this procedure are patient refusal or allergy to local anesthetic, and lastly, cellulitis overlying that needle site. So once you have patient consent, you've talked to your team about the appropriateness of a block, you want to go ahead and put the patient on the cardiac monitor, want to be measuring the blood pressure, heart rate, pulse oximetry. You want to have an intravenous line to administer any potential medications that you may need. You also want some ChloraPrep or sterile cleansing solution so that your site stays sterile and nice and clean. In addition, you need sterile gloves to perform this procedure. You also want a needle. So there are special needles that you can use for ultrasound-guided regional anesthesia, which have some echogenic notches in them. They have extension tubing as well. If you don't have anything fancy like that, you can reach for a spinal needle. As long as you have a needle that is long enough, you want about a 2 to 4 inch needle, 21 to 25 gauge, to perform this procedure. You want to visualize your needle at all times. You also need your local anesthetic. So ropivacaine or bupivacaine are 2 long-acting local anesthetics of choice, and depending on the type of block you're doing, you'll need about 15 to 30 milliliters. You want to also have a sterile probe cover on your linear transducer so that when you're doing your scanning, you have the probe sterilely covered. So let's talk about when we're going to use this. So this patient right here is a 92-year-old female who tripped over her slippers and fell to the ground. The family heard the fall, brought her into your emergency department. Based on your physical exam, there's an externally rotated shortened leg. She has significant pain in the hip. You're very suspicious that she has a hip fracture. But you need to get your x-ray, you want to get her moving, so you put that line in and think, let's just do some morphine to start. So she gets 4 milligrams of morphine, goes off to x-ray, she comes back. That was about 15 or 20 minutes, and she is crying. She says she has no pain relief at all. So she's about 60 kilograms. You look at her vital signs, she's certainly not somnolent, so you give her another 4 milligrams of morphine. You get your x-ray back, you think, whoops, there we go, she has a hip fracture. You're going to talk to the PMD, talk to orthopedics, 20 minutes go by, you get back in the room. She's still in significant pain, crying, pleading with you to give her something. You check the line, you flush the line is good. You decide to give her another 4 milligrams of morphine. So at this point, you think, my gosh, I'm giving this elderly woman 12 milligrams of morphine. But again, our goal is to get people feeling better. Now the patient has a bed. The nurse is calling to give report. You go in to talk to the family and the patient, and everybody is in distress. The patient feels horrible. She has had 12 milligrams of morphine. Her pain is intolerable and not controlled. Now you're going to wheel her upstairs, transfer her to a stretcher, and you've really gotten nowhere with her pain management. So what can we do? What we can do is a femoral nerve block or a fascia iliaca compartment block. The indications for femoral nerve block are hip fracture and femur fracture. This is a fantastic modality because it gets patients complete pain relief with prolonged pain relief that help with transferring, with bedpan use, with x-ray, and with any kind of movement in the bed. Femoral nerve block contraindications, again, which I discussed earlier, include allergy to local anesthetic, patient refusal, and cellulitis over the site. The lower extremity will be paralyzed after your femoral nerve block, but these patients are not ambulatory. So there's really no contraindications in terms of mobility because they're not walking. So geriatric hip fracture, why is it so important to control geriatric pain? I'd say practitioners are more worried about oversedating or the side effects of prescribing too many opiates in this population, but we really, as practitioners, have to also think about oligoanalgesia or undertreatment of pain. When we look at geriatric patients who are cognitively intact, inpatient, for treatment of their hip fracture, patients who receive less than 10 milligrams of intravenous morphine per day tend to have a 9 times higher rate of delirium than cognitively intact patients who receive more than 10 milligrams of morphine. What that means is when we're under-treating this terrible severe pain, it's actually leading to significantly more delirium. So when we think again of the treatment of hip fracture, yes, we want to balance out analgesic needs and side effects of opiates, but also we want to provide adequate pain relief to this population. Another study showed that patients of all the modalities or medications that could be made available, patients benefited most or had most successful pain management with ultrasound-guided regional anesthesia. So systemic opiates, immobilization, neurostimulation, multimodal analgesia, all of these options, none of them were as successful as doing a nerve block at bedside and completely blocking that pain. Yes, they may still need some opiates for breakthrough, but it will be significantly less, and the appropriate management of geriatric pain is so important to prevent delirium. So let's talk a little bit about how you do this nerve block. So this is a wonderful block to start off with if you're new to ultrasound-guided regional anesthesia because there's not many contraindications, there's not many side effects, and it's pretty easy to find. When you're using the ultrasound probe, you want to sit it right within the inguinal crease between the anterior superior iliac spine and the pubic tubercle. In this crease, when you place the ultrasound probe down, you should easily visualize a pulsating femoral artery, and that is your landmark to have success with this block. When we see our ultrasound screen, you will see the femoral artery pulsating, the femoral vein medial to it. So now we know we're in the right spot. Some little tricks to make sure that you are where you need to be. When starting off in the inguinal crease, you can track a little bit towards the feet, a little bit caudad, and you'll start to see the femoral artery split. That is too low, too inferior. You need to back up and see the femoral artery as one vessel. And again, pulsating femoral artery. And then you'll see the collapsible vein, when you apply pressure, a collapsible femoral vein medial to that. So once you have your femoral artery, you've seen that it's split, distally, you come back up, then you want to look lateral. And what you should see there is a nice femoral nerve, a wedge-shaped, somewhat honeycomb appearing with some echoes bouncing around. You'll see that is your femoral nerve, and that is your target. Holding your probe in an in-plane or preparing for an in-plane position, you will take your needle, pop through the top layers of the skin, inject a little bit of local anesthetic to form a wheel, and then you want to advance your needle slowly, visualizing the needle tip at all times. In the in-plane technique, you will see the full length of the needle so as to be sure you are not puncturing or damaging any surrounding tissue. When you do that, you will be aiming for the nerve laterally. You are avoiding the artery, which is next, and then the vein, which is completely medial to that. Your needle should be aiming for the corner pocket or just below that femoral nerve with the goal of infiltrating 15 to 30 milliliters of local anesthetic into that area above the fascia. When you do that, you will see black anechoic local anesthetic distributing below that nerve, typically lifting that nerve up off of the underlying structures below. And the local anesthetic will therefore bathe that nerve, and you should be able to have a really nice block. Local anesthetic of choice is dependent on the patient and how long you want duration of analgesia, but typically for hip fractures, because these patients are operative or certainly not getting up and walking home anytime soon, a long duration of analgesia is desired. Therefore, you'd want to reach for a ropivacaine or a bupivacaine. Both have about the same duration of action, about 12 to 24 hours, but bupivacaine tends to be a little bit more cardiotoxic, so practitioners often reach for ropivacaine 0.5%. When we are also thinking about short-acting analgesia, where we only want 1 to 2 hours of analgesia on board, you can use lidocaine. Very important math to do before your nerve block is to calculate the toxic level of local anesthetic to make sure you are well below the toxic level. When we're using lidocaine, 5 milligrams per kilogram is the cutoff. When using bupivacaine or ropivacaine, you do not want to go above 3 milligrams per kilogram of local anesthetic. And we typically do not use epinephrine with our injections, so you're going to be going without epi. So complications, dreaded complications are compartment syndrome and local anesthetic systemic toxicity. So any block that you perform, you do run the risk of local anesthetic systemic toxicity because you're using a local anesthetic. But compartment syndrome is specific typically for lower extremities, typically more for distal lower extremities like tibia fractures. But when you're dealing with a hip fracture, you still, of course, always want to worry about compartment syndrome, especially in the leg. The literature on compartment syndrome is pretty clear that despite use of regional anesthesia for pain management, compartment syndrome still presents with a severe acute change in the character of pain and is typically not missed despite regional anesthesia being performed. So in one study that was evaluating compartment syndrome detection with regional anesthesia, they found that 98% of patients exhibited the classic signs of, again, an acute change in the character of pain, intensity of the pain, despite having a nerve block on board. And there's a lot of military literature about compartment syndrome and regional anesthesia. And again, they all favor the use of regional anesthesia for the management of extremity pain. The most important thing when evaluating for compartment syndrome is being sure to have routine, diligent neurovascular exams performed. Regardless of whether or not there is a nerve block on board, anybody with a fracture needs to have diligent neurovascular testing. And this holds true whenever regional anesthesia is employed because you want to really make sure you are checking and evaluating for all of the neurovascular components necessary. Local anesthetic systemic toxicity, again, is an entity that any patient is at risk for anytime you're administering local anesthetic. Local anesthetic systemic toxicity depends on a few things. It depends on the volume of local anesthetic administered, depends on the concentration, and as well as the location. Some locations throughout the body, especially the neck area, have more vascularity and may be at risk for increased rapid uptake of local anesthetic. So these are things to be considered. And again, calculating your maximum dose of local anesthetic prior to administration is very important. L.A.S.T has a spectrum of presentations. It can present in a mild form, which you'll have some ringing in the ears, you might have a little bit of paresthesia, a little bit of headache, or sometimes visual disturbances. And in the most severe form, you could potentially have cardiopulmonary arrest or cardiovascular collapse. So this is partly why we place patients on a cardiac monitor and have intravenous access available. If patients have any sign of severe L.A.S.T, you want to administer antidote immediately. So what is the treatment? If it is in the mild to moderate neurologic presentation, again, you may see some ringing of the ears, stroke-like symptoms, or seizure. For the seizure component of it, benzodiazepines are indicated just as if you would give for any other seizure. However, when we are losing airway or we are having issues with cardiovascular compromise, we want to remember our ABCs and, of course, ACLS. If the patient is significantly decompensating and goes into a VFib, this is a very high mortality situation. You need to be aggressive, and you may even want to consider cardiopulmonary bypass at this point. If the patient does go into cardiovascular collapse, hypotension, VFib, or you're noticing that we're getting a thready pulse and the patient is going downhill, you need to administer intralipids immediately. Intralipids are not for when the patient is getting CPR. Intralipids are to prevent CPR because once the patient does decompensate completely, the mortality is very high. So any suspicion that we're going in the wrong direction cardiovascularly after local anesthetic administration, intralipids are indicated. They should always be within reach, whether it's in your Pyxis department or in your ultrasound guided regional anesthesia carts, and you need to make sure that you check their availability and also check the expiration date prior to every block you perform. The dosing is 1 milliliter per kilogram of a 20% lipid emulsion. You want to give that in bolus form every 5 minutes, and the max dose of intralipids will be 3 milliliters per kilogram. You can also use an infusion after that of a 0.25 milliliter per kilogram per minute, 20% lipid infusion. So you want to bolus immediately every 5 minutes, titrate to stability, but once you get to 3 milliliters per kilogram, if you're still okay, you want to start them on an infusion. So, in summary, when we think about geriatric hip fracture, we want to think, what can we give that is quick and effective? What do we want to do to treat the pain but not flood geriatric patients with opiates, not oversedate, not lead to poor outcomes, but really truly treat their pain? What do we want to think about in terms of delirium? We want to remember that yes, opiates can contribute to delirium, but in fact, undertreatment of pain can as well. And we want to try to give good care to our senior population. All of these are reasons to entertain ultrasound-guided regional anesthesia for your hip fracture patients. Again, you want to place that probe in the inguinal crease, see the pulsating femoral artery, and go lateral to that. It is a relatively easy superficial block. Calculate your local anesthetic, make sure the patient is on a monitor, and watch as you see immediate relief of that severe, terrible hip pain, and you probably get yourself a hug afterwards. So thank you so much. I appreciate all of your time and the opportunity to speak to you about this, and hopefully we'll get to talk more. Thanks.